Welcome, everybody. Today we are at the fourth episode of Trainee Pearls, and we have the pleasure to have with us Dr. Christopher Gibson from the Department of Medical Oncology, Division of Hematological Malignancies at Dana-Farber Cancer Institute of Boston, Massachusetts. Christopher, first of all, thank you for accepting our invitation.
Oh, not at all. Thanks so much for having me.
How are you today?
To be here. I'm great.
Thank you. It's a pleasure for us to have you. So let's go to the nitty-gritty of chip in donors and its implication for bone marrow transplant. The main focus of your recent paper on JCO journal. So can you define clonal hematopoiesis and why is it important in the context of allogenic bone marrow transplant?
Sure. So I'll just start out by making a little bit of a distinction between clonal hematopoiesis as a general term and then CHIP as a more specific term. So clonal hematopoiesis just means, any clonal expansion of hematopoietic cells. And, we think that this usually starts with asymmetric expansion of a stem cell. And then, that stem cell's progeny then sort of have outsized representation in the total hematopoietic cell pool. And we can detect that with a number of methods, but one of the easiest ways of detecting it is by detecting genetic mutations that are acquired by the stem cell. And then if you can show that that mutation is present in a greater proportion of the total hematopoietic cell representation than it should be, then you can infer that hematopoietic stem cell clone is larger with respect to other hematopoietic stem cells than it should be. But clonal hematopoiesis, just as a general term, doesn't tell you anything more than that. And CHIP is a more specific term that was coined to try to sort of tell you more about the specific characteristics of a certain subset of clonal hematopoiesis. And so one of the characteristics is that it's a large clone. And so the official definition of CHIP uses a variant allele fraction cutoff of 2%. Just to sort of try to say that these clones need to be large enough that we think that they actually are exerting some kind of influence. And then they're also defined by recurrent mutations in a particular set of genes. And these are genes that we find recurrently mutated in mostly myeloid malignancies like acute myeloid leukemia and myelodysplastic syndrome. So rather than being just sort of any mutations that you find, CHIP is, clones with an allele fraction of 2% with recurrent mutations in this particular set of genes. And it's important to sort of make that distinction because in the paper, we actually looked for more than just CHIP. We looked for a sort of clonal hematopoiesis that would not just meet the definition of CHIP. Now, getting back to the question of why it's important in hematopoietic stem cell transplant. So, clonal hematopoiesis by its definition is asymptomatic, but we know from other studies of clonal hematopoiesis in the non-donor population that it can have impacts on outcomes. So, for example, it's been shown to increase the risk of cardiovascular disease and increase the risk of death. And so we initially reasoned that because it's asymptomatic and by definition to have CHIP, you don't have abnormalities in your blood counts. And so we reasoned that this could very easily be occurring in some hematopoietic transplant donors and being passed to their recipients. And because we knew that in, non-transplant individuals, it could have outcomes, we wanted to know whether or not this was actually happening with frequency. And if so, if it was having an impact on recipient outcomes.
Perfect. Yeah, and thank you for these underpinnings of the definition of clonal hematopoiesis and CHIP exactly. And now we are really assisting to a growing interest as to CHIP and relationship with the many other disorders we've seen at ASH with Alzheimer and previously with a rheumatologic disorder and COPD. So now could you explain better the design of your study?
Right. So before this study, we did, a smaller proof of concept study where we were able to show that in some in some transplant recipients who had persistent unexplained cytopenias after transplant, those patients had received clonal hematopoiesis from their donors with DNMT3A mutations. So we knew that it could happen. But then what we were wondering was, how frequently does it actually happen, and what are the outcomes? So we collaborated with investigators from Johns Hopkins in a bi-institutional study, and we sequenced the donor products from a set of a little bit more than 1,700 donors, all of whom we decided we would look only at donors who are age 40 or older, because clonal hematopoiesis is an age-related phenomenon. And so we just thought that below age 40, we would not find it frequently enough to be economical to do all the sequencing. So we basically focused on a set of donors who are age 40 or older, and we sequenced with a targeted panel that covered the genes that are most frequently recurrently mutated in CHIP. But as opposed to studies of CHIP, in this case, we actually sequenced a little bit more deeply. So we were able to identify smaller clones. And then we basically identified CHIP and then associated that with recipient outcomes for the paired recipients of those donors.
Okay, so can I ask you, what was the proportion of the donor you found mutated? And which genes did you find most recurrently mutated?
Right. So when we looked at sort of the technical the technical performance of our assay, we were able to identify CHIP down to an allele fraction of 0.5% across all samples. So that was the cutoff for our definition of clonal hematopoiesis. That would correspond to a mutation that's, if it's a somatic mutation on an autosome, that would correspond to a mutation that's present in about 1% of cells in the sample. And so with that definition, we identified clonal hematopoiesis in about 22.5% of donors. If we used a higher allele fraction cutoff of, say, 1%, then that fell to about 14% of donors. So a minority, but a substantial minority. And the most commonly mutated genes were things similar to what we've seen in the non-transplant population. So mutations in the gene DNMT3A were most common by far, followed by mutations in the gene TET2. Then there was a big drop off. We saw mutations in the gene ASXL1 in a smaller number of patients, and a small number of mutations in the gene PPM1D. And after that, things really dropped off, and there were no other genes that were mutated in more than 10 patients in the study after that.
Okay, so you basically recapitulated the finding of ARCH, let's say, as the most recurrent mutated genes, the DAT,
yes,
the DNMT3, ASXL1, and TET2.
That's right.
And it obviously makes sense also, like, studying donors above this cutoff you set in order to have basically events to study and correlate with the outcome. So did you find difference in donor who carried this lesion and in the relationship, for example, with diagnosis, myeloid versus lymphoid disorders in related donors, for instance, like in a similar study that was previously published always in the JCO?
Right. So the only donor characteristic that we found an association with was age. So you're right. That's in. So I believe in the study that was the Frick study that was published a couple years ago in JCO. They did find an association between donor CH and the recipient's disease. We didn't see that. We did initially see in univariable analysis. We saw an association. We saw a higher proportion of CHIP in related donors versus unrelated donors. We had about 25% of this study was from unrelated donor products, but that was really just due to the fact that the related donors were older than the unrelated donors. And once we controlled for donor age, there was no relationship between between donor relatedness and the likelihood of CHIP. And we didn't see an association between donor CH and the recipient disease. So we didn't recapitulate that finding.
Oh, I see. And how did the presence of CH lesions impact on the recipient outcomes? For example, did the VIF of specific gene have any role?
Yeah. So it's a great question. Um, so we actually wanted to interrogate that rigorously, and so as opposed to what we and others have done in prior studies where we just sort of drew an arbitrary cutoff and said we'll look at outcomes at a VAF cutoff of 0.5% and 1%, and just sort of look there. We actually looked at the hazard of progression-free survival, which was our primary recipient outcome, with sort of increasing VAF of the donor CH mutations as a continuous function. And so we were actually able to see where there was an inflection point. So what we saw was that at allele fractions below 1%, and certainly down at close to 0.5%, there really was not much of an impact on outcomes. But we did start to see a decrement, or an improvement in recipient progression-free survival as the allele fraction of the donor CH got higher. And that inflection point was greatest at around an allele fraction of 1%. So what we eventually saw was that recipients of donor CH at an allele fraction of 1% or greater had improved progression-free survival compared with recipients whose donors did not have CH. But below that, no impact on outcomes.
I see. So maybe this also will help maybe reclassify the cutoff for CHIP in the future. Who knows? Right?
Yeah, I think it's a good question. I mean, it's hard to extrapolate outcomes from a transplant study to the non-transplant population, but I do think it makes the point that the original definition of CHIP, that allele fraction definition was a little bit arbitrary, and part of it was really driven by technical considerations. So the original studies of CHIP were done based on exome sequencing, which has lower depth of coverage, and therefore the clones that it can identify are smaller. And what the folks who kind of came up with that provisional definition of CHIP noticed was that there was a clear relationship between the allele fraction of CHIP and the likelihood of impact on recipient outcomes. And so they sort of said, we want to come up with something that, some sort of size cutoff, but they couldn't interrogate deeply enough to know, is 2% really the right cutoff or not? So I do think this suggests that if you were to go back and sort of do deeper sequencing and identify more CHIP, maybe the right cutoff would be something lower. And in our study, the right cutoff appeared to be 1%. But it's hard to know whether that would be the same in a non-transplant cohort. But I think it's worth thinking about.
Sure, I also agree. And did all the CH lesion you find in donors engraft in recipient? Or in other words, did you notice a 100% concordance in the degree of a recapitulation of clonal hematopoiesis between donor and recipient? Or also in this case, the gene mutator, the gene mutation rather than the functional effect of the mutation rather than the VIF have any role in the clonal dynamics of recapitulation between donors and recipients?
Yeah, it's a good question. So we didn't assess post-transplant engraftment in all of our patients, just in a subset. But in the subset that we tested, we saw a very high rate of engraftment, not 100%, but greater than 85% engraftment of donor clones when the mutation was in DNMT3A or TET2. But in other mutations, the rate of engraftment was lower. It was, more on the order of 60-something%. We don't know why that is. For one thing, we had a smaller number of mutations in other genes just because of the lower frequency of those mutations. So it's a little bit harder to draw conclusions. What we can say for sure is that mutations in DNMT3A or TET2 are very likely to engraft, and maybe some of these other mutations are less likely to engraft. Maybe it's possible that in some cases, some of these mutations in other genes are actually not in a stem cell that has engrafting potential. So maybe not in, whatever you would consider to be the equivalent of an LTHSC. And so maybe some of these other mutations are occurring in some sort of shorter term HSC or even some kind of more differentiated progenitor cell. And we're just sort of picking them up in the sequencing and they have some different biology. But it's, or maybe they, they sort of confer other attributes. They change the function of the hematopoietic stem cells that they occur in such that those hematopoietic stem cells no longer have good engraftment potential. Or the other possibility is that they do engraft, but that they don't have much of a clonal advantage in post-transplant hematopoiesis. And so by the time we actually assess them, the allele fraction was below our limit of detection. So, it's hard to say for sure, but it's, sort of a provocative finding. There did seem to be a difference. And DNMT3A and TET2 were very likely to engraft.
Yeah, of course. And it's also probably related to the different self-renewal capability that are imprinted by the different type of mutation, of course.
Yeah.
It's
that's
a war of clones for the fittest one.
Right.
And
right.
Selection.
Yeah.
Can you tell us what is your hypothesis instead for the underlying link between DNMT3A clonal hematopoiesis and the increased risk of a chronic GVHD that you saw? And also, can you comment on the data you have about the cytokines you studied?
Yeah. Sure. So we, in a subset of patients, we assessed cytokines at a set of cytokines at 3 and 12 months post-transplant in the recipients. And some of these patients had donor CH and some didn't. And what we found were that the recipients of donor CH did have evidence of potentiated inflammatory signaling. So they had higher levels of IL-12 P70, which has been associated with graft versus host disease and the graft versus leukemia effect in other studies. And then they also had evidence of sort of an association and an activation of a network of cytokines that included IL-12 P70 with sort of a negative association with another set of anti-correlated cytokines. So there was evidence that they had some potentiated inflammatory signaling, and that could relate to the risk of graft versus host disease. Now, why that is, I think it's too soon to say, and there are a couple of potential reasons. We know that these mutations are in hematopoietic stem cells, and it's been shown in our work and other groups' work that they can distribute into many different hematopoietic lineages. So they can be in the myeloid compartment. They can also be in the T cell compartment. And there's been a lot of nice work done, especially just in the last couple of years, that sort of dissects what the effect of DNMT3A loss is in these different compartments. And so we know that it actually has direct effects in T cells. So it's been shown, for example, that loss of DNMT3A or methyltransferase function makes T cells more resistant to exhaustion, may also change some of their differentiation state capabilities. And we also know that the mutations have effects in myeloid cells as well. So I think this kind of opens up a potential area for next steps in investigation, is really trying to disentangle what's going on here. So one possibility is that the effects are primarily from the mutations effects in myeloid cells, and that is augmenting inflammatory crosstalk from myeloid cells via cytokines to T cells. Or another possibility is that there is also a direct effect in T cells through some of these effects of DNMT3A loss in T cells themselves.
Okay, and you also found difference in this patient with DNMT3A clonal hematopoiesis as to the different type of GVHD prophylaxis, right? And outcome.
Yes. Yeah, so that's why we think that more than likely, whatever the explanation for the effect, for the increased prevalence of GVHD and the decreased risk of relapse that we see in recipients of donor DNMT3A mutations, we think whatever it is has to go through T cells in some way, because we saw the effects that we saw were only in patients who didn't receive post-transplant cyclophosphamide. And in patients who did receive post-transplant cyclophosphamide, we really did not see any impact on the rate of chronic graft versus host disease or on the rate of relapse. And so what we hypothesize is based on what's known about the mechanism of PT-Cy. So PT-Cy is known to pretty effectively either deplete or sort of inactivate alloimmune T cells. And so what we hypothesize is happening is that in those patients that those are required for this effect to manifest. But that doesn't tell you whether or not the effect is actually coming indirectly from crosstalk from DNMT3A mutant myeloid cells, or whether it's actually coming directly from effects in T cells. All it's telling you is that the alloimmune T cells are necessary for mediation of the effect. And I will just sort of say, just taking a step back, the caveat here is that that there are other characteristics of transplants that go along with the use of post-transplant cyclophosphamide. And so we can't say for sure, these are mostly done, especially in our study, that PT-Cy was mostly given with haploidentical transplants. And those were mostly done in patients who received bone marrow grafts rather than PBSC grafts. And so we can't fully disentangle all of those variables. And so what we can say is that to the best of our ability, when we tried to isolate these other variables, we didn't see any effect that they were what was actually driving this effect. So we were able to look at, to some extent, at patients who had gotten, either PBSC grafts or bone marrow grafts with other types of GVHD prophylaxis. Or comparing haplo versus fully matched transplants, and those, as best as we could tell, didn't seem to be what was responsible for the effect. But we still can't say with 100% certainty that it was the PT-Cy. That's just our best guess, and I think the hypothesis flows from that, from that assumption. But it's something worth testing.
Right, but you did see improved outcomes of these DNMT3 CH carriers, right?
Yes, right, globally. But that was largely driven by the subset of patients who received traditional calcineurin inhibitor-based GVHD prophylaxis, and when you looked at the patients who got PT-Cy based prophylaxis, we really didn't see any improvement in outcomes. We didn't see worse outcomes. They were just basically no better. And so the bulk of the improvement was driven by the traditional CNI based therapy.
So what about now the fraction of patients experiencing the most feared complication that is also the reason why we study CH in these patients? So the donor-derived cell leukemia, which mutations are mostly involved in this process?
Yeah. So as in other settings, donor cell leukemia in this cohort was rare. So we had 8 total patients in the cohort that developed donor cell leukemia. I will say that's actually a rate that's slightly higher than what's been described in some other studies. So there are some registry studies that estimate the rate to be about 0.1%, 0.1%. This rate is slightly higher than that. We really looked carefully for these cases, and so it's possible that because we were able to focus in a little bit more than in like a registry level study, that we were able to detect a few more cases than might have otherwise been detected. But in any case, the numbers are so small, it's not really worth getting obsessed about the exact frequency. I think what was notable in these cases was that when we looked at whether or not these patients were patients who had donor CH, some of them were. 6 of the 8 did have CH that came from their donors, but it wasn't the typical DNMT3A or TET2 mutant CH that was most common in the total cohort. It was actually less common types of CH. So one bucket were patients who received TP53 mutations in their CH from their donors. So there were 2 of those patients who developed DCLs. And that was actually out of only 5 total P53 mutations in the cohort. So 2 of those 5 went on to develop donor cell leukemia. Another subset were patients whose donor CH had splicing factor mutations, as we find frequently in myelodysplastic syndrome. And so the rate there was, that was also sort of a rare subset, but, we had 3 of those patients who developed donor cell leukemia. And then there's this final subset that was actually not somatic mutations, but in 2 cases, we found donor cell leukemias arising in patients who actually had previously unknown germline DDX41 mutations. And in both cases, those patients had a sibling donor who were also not known to carry the DDX41 mutation at the time of stem cell donation. But then it turns out they did, and the donor cell leukemia evolved in donor cells as a result of the germline DDX41 mutation. And in one of those cases, we, were actually able to go back, and the patient's related donor had actually presented to a sister institution of ours with MDS about 10 years after stem cell donation. Myeloid malignancy predisposition. In the other case, the donor was lost to follow-up.
I see.
But I think the big take-home point there was like no patient who had just sole DNMT3A or TET2 mutated CH went on to develop donor cell leukemia in the study. So it all kind of arose from these much less typical buckets of clonal hematopoiesis.
And this is also like somehow recapitulating what we know about therapy-related myeloid neoplasm.
Yeah.
Of course, the mutation that popped up in your analysis were TP53. I'm kind of surprised for PPM1D, for example, because these was around like among the most frequent as hematopoiesis, but then didn't impact on the rate of donor-derived leukemia. So probably there is also difference in TP53 and PPM1D, because PPM1D we know better that needs exposure to particular chemotherapy agent. So of course, when you subvert the bone marrow hematopoiesis, but then you don't treat the patient with chemotherapy, possibly it's different than like TP53.
Yeah, there's something really interesting about the difference in PPM1D and P53 mutations. We don't fully understand it yet, because even though, as you say, even though they both inactivate the DNA damage response pathway, they do seem to confer very different clinical risks. And that's been shown in a couple of different papers. So one way of looking at it, so Coleman Lindsley, who was the senior author from DFCI on this paper, had a paper in the New England Journal a few years ago where he studied basically the genetics of patients with myelodysplastic syndrome who are undergoing stem cell transplant. And one of the things that he found there was that P53 mutations in MDS, as we know, are confer very poor prognosis, very high risk of relapse. What he found in that study was that those P53 mutations occur very frequently with PPM1D mutations, and they were both strongly related to a risk to having received prior chemotherapy. But actually, if you looked at the phenotype of the MDS, it was largely related to the P53 mutation. So P53 mutations were associated with having a complex or adverse karyotype, but PPM1D mutations were not. And although PPM1D mutations in univariable analysis were associated with inferior, with poor survival and high relapse, that was really all driven by the co-mutation with P53. And when you controlled for that, then there was actually no adverse impact of having PPM1D mutations. So they are highly associated with chemotherapy, but don't appear to confer any sort of prognostic effect. And then if you go the other way and look at, the risks that both of those confer on the risk of developing myeloid neoplasm, again, it looks like there's a difference. And so that's been shown in a couple of places. One place where it was shown, I think nicely, was a paper from WashU The first author was Terrence Wong, and that came out a couple of years ago in Cell Stem Cell, and they studied patients who had clonal hematopoiesis after autologous stem cell transplant, and then they looked at a bunch of patients who developed therapy-related myeloid neoplasms, and what they found was that in those patients who, when they had p53 mutations, the p53 mutations were expanded in the therapy-related MDS or AML, but when they had PPM1D mutations, they were not expanded. Sometimes they weren't actually even present in the MDS or AML, but when they were not expanded. They were sort of about the same size that they had been at the time, which might suggest that they're actually not in the primary clone that's driving the MDS or AML. So maybe they're in some sort of bystander clone or something like that. So it may be that they're a marker of the prior chemotherapy and those clones are selected for by chemo, but they don't have a lot of independent malignant potential. So there's a clear, there's definitely something going on with those, but still here as well, it looks like, the risk of DCL is greatly increased by having a P53 mutation, but not so much by having a PPM1D mutation.
Yeah. No, what I was saying is that basically recapitulate what we also know, as you said, from the literature about PPM1D and the risk of therapy-related myeloid neoplasia. Also, there is another paper showing its relationship with prior exposure to certain therapeutic agents.
Mm-hmm.
Latin, so
right.
Definitely it's not the case in the context of bone
right.
Transplant.
Right.
So personal consideration now, taking into account yours and previous findings, what is your practical advice for bone marrow transplant physician? Would you screen all donors for clonal hematopoiesis, only older donor? And by older here, I just want to say that older is just for the sake of being
right,
because otherwise will be upset at me.
Yeah, that's right. It's a hard question. As provocative as I think the data are, I'm not sure that they in and of themselves fully support screening all donors yet. Part of that is because so far it's not clear what we would do with all of those results, and so I personally in my practice I don't try to screen donors. I mean, we're walled off from donors anyway, but I would not try to screen older donors for all clonal hematopoiesis. What I can say is that if clonal hematopoiesis were found incidentally in a donor, a DNMT3A or a TET2 mutation would not be an exclusionary criteria in and of itself. Now, that statement has to be qualified because, most of the scenarios I'm aware of in which clonal hematopoiesis has been found in a donor doesn't really qualify as asymptomatic screening, because in most cases, the testing was done for some reason, like the donor had some sort of CBC abnormality, like an elevated MCV or something that was funny about their CBC that prompted the clinician to then sequence their blood, and then they found that. That is not the definition of clonal hematopoiesis, because by definition, clonal hematopoiesis means that you have to have a normal CBC, and so you wouldn't, the person who has clonal hematopoiesis, you wouldn't actually think to test them. You would only detect it through asymptomatic screening. So I would sort of say that with a note of caution that most of the time right now, if you're not doing routine screening on everyone, if you find clonal hematopoiesis, it probably doesn't actually fit that scenario, because you were probably doing the testing because you were concerned about the donor. And so in those cases, you have to ask yourself, like, is this really clonal hematopoiesis? Is it possible that I'm actually picking up MDS, something that, is actually, or CCUS, or something that's actually driving, more of some sort of CBC abnormality. The other thing that I think you could say that we have a little bit more basis for would be, if there were some interest in a limited sequencing panel to sequence donors for the small subset of genes that we actually think might really be problematic if there were a mutation passed to the recipient, things like P53, splicing factor mutations, maybe a limited panel of germline mutations. You know, that we would find those mutations very rarely, but targeted sequencing is actually quite inexpensive these days. It can really be done pretty inexpensively. And so I don't think cost is actually really an argument against it. We do much more expensive testing on donors routinely. And so I do think that you could make that argument, because I think, you know, for example, if you found a P53 mutation in a donor, you know, I don't think many transplanters would want to use that donor. And I think they would, you know, probably be supported by the evidence in that. So that, you know, would still require a lot of discussion and a lot of coordination to make sure that there were sort of standardized testing platforms and algorithms, and that everybody was in agreement about what you could do with it. But I think you could make more of an argument for that than sort of broadly sequencing everybody for like DNMT3A and TET2, where, you know, it's hard to know what you would actually do with those results.
Right. And now a provocative question based on also what you've just said. So in a hypothetical scenario, let's say you, and with your, of course, current knowledge, would you rather use an older sibling with a CH in DNMT3A, provided that, of course, is going to use a calcineurin-based prophylaxis of GVHD, and all the CMV and ABO status and all these variables are okay, or a younger matched unrelated donor with no clonal hematopoiesis?
You're right, that is a provocative question. And so, I'll sidestep it a little bit and say that, the results of our data, the results of our study really don't shed any light on that question. And I think, people are, sort of often ask us that, but we really don't know, because we didn't have a comparison there since we didn't sequence younger donors. I think, rather than saying what I would prefer, I think that if there were compelling reason for a clinician to want to use that patient's related sibling and they had a DNMT3A mutation, I don't think the DNMT3A mutation would be exclusionary. But I think, you would want to consider what which is that, that graft is maybe slightly more likely to be associated with a higher risk of chronic graft versus host disease. But we don't really know much else about the comparison. What I would say, just sort of pivoting a little bit, when people have sort of asked me about this, I think that actually the implications of this study are probably broader than just the narrow implications for clinical donor selection. And maybe the broader implications are what it is telling us about the biology of graft versus host disease and the GVL, and the impact in particular of de novo DNA methylation in that. And so this may be something that can be manipulated more broadly by efforts to recapitulate the molecular effect of DNMT3A loss in especially high-risk patients. So if we know that that loss of DNA methylation capability, which is what's conferred by these DNMT3A mutations, if we know that that's associated with reduced relapse, as long as you don't use PT-Cy, there may be room for trying to augment the GVL in particularly high-risk patients by trying to recapitulate that, whether that would be treatment with hypomethylating agents, which would be sort of a crude way of doing it, or even thinking about things like gene editing in DLI products, for example, for relapse patients or something like that, to really try to boost the GVL. And I think that might actually be where the biggest implications of this study. And actually, just to point out that the same finding was actually made in the Frick study as well. So they actually also found a reduced risk of relapse and higher GVHD in their study. They just weren't big enough probably to see the survival impact. But I think, two studies with sort of similar findings, makes a trend. And I think that it may be that the bigger long-term implications of those are actually for how we think about that biology, and beyond just the sort of narrow question of donor selection.
I see. So thank you so much for such a great talk about clonal hematopoiesis and its implication in bone marrow transplant. Thank you again for being with us today, and I'll see you next time for another Trainee Pearls. Bye-bye.
Oh, it's my pleasure. Thanks so much for inviting me.
Bye.